والسلام على خاتم المرسلين. Professors and colleagues, our topics today will be about the advanced diffusion sequences. The advanced diffusion sequence, we are aiming to explain the kurtosis and IVIM, just the basic principles and clinical application. Beginning by kurtosis, all of us, we know that in free diffusion, there is free movement of the protons of the water molecules in the extracellular space. And in this condition, there is a high ADC. On the contrary, in restricted diffusion, plenty of cells, narrow extracellular space, limited movement, so there is low ADC. Just a small word to know how we calculate the ADC. Remember, we are aiming to use multiple p-values. As we increase the p-values, there is drop of the signal. So by this curve, we can see that with increased p-value, there is drop of the signal, and this is how we can calculate the ADC. If we are dealing with a homogeneous medium, so the proton movement will follow a Gaussian distribution. And in this condition, the movement can be presented by what we call a bell curve. This is the bell curve. In free diffusion, the bell curve is wide. In restricted diffusion, the bell curve is narrow. The width of this bell curve represents the ADC. So the ADC is high in free diffusion or wide bell curve, and the ADC is low in restricted diffusion or narrow bell curve. But in reality, we are not dealing with homogeneous medium. We are dealing with heterogeneous medium, plenty of cells, cell membrane, so that the movement, this movement will follow what we call a non-Gaussian distribution. And in this condition, the movement will be represented by a peak curve, not a bell curve. So this was the bell curve, and this is the peak curve. The difference between both curves can be mathematically measured, and this is what we call kurtosis. So kurtosis is the difference between the bell curve and the peak curve. Following the non-Gaussian distribution, remember in free diffusion, we said there is high ADC. And meanwhile, the peak curve is so close to the bell curve. The difference is minimal, so it is a low kurtosis. So free diffusion, there is high ADC, low kurtosis. On the contrary, in restricted diffusion, we said there is low ADC, but the peak curve is so different from the bell curve. The difference is high, so we have high perfusion. Now, let us return back to the curve. This is the green one is the original ADC, and the black one is the kurtosis ADC. Look, there is a difference between both of them when the p-value is more than 1,000. Do you think that this small difference really matters? Let us see. They did a test. This is a phantom filled by sucrose of different concentration, and the F is a paste of asparagus. Using the conventional diffusion, the ADC couldn't differentiate between them. But if we are using kurtosis, the paste of asparagus was nicely differentiated from the rest. So kurtosis really matters. Now, what is the sequence of kurtosis? It is just a sequence of diffusion tensor in condition to use two p-values more than 1,000 and to evaluate more than 15 directions. It is just a normal diffusion tensor sequence which takes about 7 minutes. Now, what are the parameters used in diffusion kurtosis? We have what we call mean kurtosis. It is a unitless numerical value. Units, no units. It is just a number more than 0. It increases according to the microstructure complexity and decrease in neuronal loss. The other one is diffusion kurtosis, which corresponds to our ADC. In some machines, we can get two other factors called radial kurtosis and axial kurtosis. The radial kurtosis corresponds to myelin integrity. It will decrease in myelin breakdown. Axial kurtosis corresponding to axonal integrity, which will increase in neuronal loss like in stroke. Now, what are the clinical application of this kurtosis? There are many, beginning by the first one, in stroke. In stroke, if the lesion is more than 1 centimeter, they found that the final lesion size after 1 month on T2 is corresponding to the original size in the kurtosis map. This is a case of acute infarction. This is the size of the infarction and diffusion. After 1 month, the T2, the lesion is nearly half the original one. And you can see that it's closely matching the size in the mean kurtosis map, which was done initially. If the size of the infarction is small, so that the number, the final number in T2 image after 1 month is also closely related to the size, to the number in the initial mean kurtosis. Example, in the literature, in ADC map, the number is nearly double in the acute stage, the terminal number in T2 after 1 month. But this number is closely matching the number in mean kurtosis map. Lastly, in stroke, there are microstructural abnormalities. These microstructural abnormalities are due to beading that occur in the axons during stroke, and these are reflected by increased axial kurtosis. Another application is traumatic brain injury. Sometimes in traumatic brain injury, the COMR is totally normal, while in mean kurtosis, there are areas that are showing increase. Let us see an example. This is a case of coup and contour-coup hemorrhagic contusions on FLAIR, T2, and SW, and look for the area between the ventricle and the hemorrhagic contusion. The white matter here is appearing normal, totally normal. Look in the mean kurtosis. This area is occupied by area of increased mean kurtosis. This reflects astrogliosis or glial skull formation, which is not seen by any other conventional sequence. In neoplasm, our goal always is to differentiate high and low-grade tumor without biopsy. They found that mean kurtosis is high in high tumor, high grade, low in low grade. And we can see these are cases of astrocytoma grade 2, grade 3, and glioblastoma grade 4. In the mean kurtosis map, it is hypo or of low grade on T2, hyper intense or higher grade in glioblastoma, intermediate signal or intermediate value in grade 3. We are working to get a cutoff values, and we have a work in progress along these mean kurtosis. Another activity in neoplasm, we want to differentiate between a recurrent tumor and post-irradiation necrosis. Both of them are enhancing. And they found that mean kurtosis is higher in recurrence. This one of our cases is a case with enhancing nodule in the paracentral nodule, in the paracentral lobule. We see at spectroscopy, the choline creatine was about 2.5, denoting recurrence. After a full course of irradiation, there is still enhancing nodule at the paracentral lobule. But this time, the choline NAA is so dropped to 0.7, it is hypoperfused. Now look to the mean kurtosis. It was here 1,000 and dropped in the post-radiation to 200. So the mean kurtosis can help to differentiate without contrast administration. Again, we are working on that to reach cutoff values. For the neurodegenerative diseases, our problem that we want to have an early biomarker to begin therapy very early before neuronal loss. This we meet this in Alzheimer and mild cognitive impairment, where there is early decrease in mean kurtosis in corpus callosum, corona radiata, and other areas. This is a case of Alzheimer's disease versus control, mild cognitive impairment versus control. And you can see all these areas shows areas of decreased mean kurtosis, while still no changes at all in the conventional MRI sequence. Same thing in Parkinsonism. Clinically, it is manifest after loss of 80% of dopaminergic neuron, while very early there is drop of the mean kurtosis in substantia nigra, red nucleus, globus pallidi. And we can diagnose this even changes in conventional MRI. Lastly, in demyelinating diseases, there is definite decrease in mean kurtosis and radial kurtosis, both in normal appearing white matter as also in normal appearing gray matter. So that we can see that the mean kurtosis is very sensitive. So it has different values for the healthy control, for the areas of the normal appearing white matter in MS patient, areas of enhancing patches, areas of hyper-intense patches, and even in the black holes. All of them had different values of mean kurtosis. While if we are looking to the ADC, you can see that the ADC has nearly comparable values and cannot differentiate between all of them. Now, let us pass to the second part, which is the intravoxel incoherent motion, IVIM. It is not intravenous, intramuscular. It's just intravoxelar incoherent motion. Now, returning back, inside each voxel, there is moving protons in the extracellular space. But also, we have to remember there are vessels in the voxels. And inside these vessels, there are protons moving in these vessels. And diffusion sequence will measure movement of protons, whether in the extracellular space or in the vessels. So actually, the diffusion sequence will measure two types of diffusion. We will have the extracellular moving proton, we will call cellular or true diffusion, and the moving protons in the vessels that we will call perfusion or pseudo-diffusion. If we are using low B-value, we will measure movement of the protons only inside the vessel, or we will measure perfusion. If we are using higher B-value, we can measure both of them, the extracellular and the intravascular, so we can measure the cellular as well as the perfusion. Remember that in free diffusion, there are scanty vessels, low number of vessels, so there will be low perfusion. On the contrary, in restricted diffusion, there are multiple cells, so multiple vessels, so multiple blood flowing inside the vessels, so normally there will be high perfusion. And we remember that in free diffusion, there were high ADC. So in free diffusion, there is high ADC, but low perfusion. And this is the origin of what we call intravoxel incoherent motion, because the diffusion in each voxel is going in an opposite way. Here, in free diffusion, it's high ADC, but low perfusion. And in restricted diffusion, there is low ADC, but plenty of vessel, so there is high perfusion. Now, the sequence of the IVIM is just like the DTI, but we must choose 3B values less than 200 milliseconds. If we are returning to the curve again, the low B value less than 200, we are investigating IVIM. If we are using B value more than 1,000, we are measuring the kurtosis. And between both of them, this is the conventional ADC, or what we call ADC 0. Now, what are the parameters for IVIM? If we are calling ADC, or what we call ADC 0, this reflects diffusion in cellular and perfusion, the cellular or extracellular diffusion, and the perfusion or the flowing inside the vessel. If we want the diffusion of cellular portion only, we call it diffusion coefficient, and this is called slow ADC. If we want the ADC for the perfusion part only, we call it pseudo-diffusion coefficient, or D star, or fast ADC. And lastly, we have the perfusion fraction. What is the perfusion fraction? It is just a % of volume of the blood inside the voxel. Now, what are the clinical applications? The first one is stroke. There is, in an ischemic core, normally there is decrease in the perfusion and the D star. If we multiply both of them, we reach CBF, or cerebral blood flow. But the innovated area that we can get the penumbra from the perfusion fraction. Look, this is a case of acute infarction, and this is the perfusion map. The difference between the infarcted area on ADC and perfusion, the difference is the penumbra. Again, without contrast administration. Also, in the cerebral small vessel disease, which will end by lacunar infarct and vascular dementia, there is suffering white matter. The white matter is suffering, and as an autoregulation manner for this white matter, there is vasodilatation resulting in increased cerebral blood flow to prevent cognitive loss. This increase in cerebral blood flow will be translated by increased perfusion. This is an example of normal patient, normal white matter, normal perfusion fraction map. This is a patient with subcortical arteriosclerotic encephalopathy. Here, the periventricular bands, and also there are areas of normal appearing white matter. These areas of normal appearing white matter shows increased perfusion area due to underlying vasodilatation. Again, in neoplasm, our goal to differentiate high and low grade, again, increased perfusion and D star in higher grade than lower grade. And we can see this is a case of glioblastoma blood grade 4. We can see higher values in perfusion and diffusion star. Again, we are working on that, trying to reach cutoff values. Also, again, to differentiate between recurrence and radiation necrosis, increased perfusion fraction in recurrence. We can see here the color is nearly orange to red, denoting higher values, while in radiation necrosis, it was green to blue, denoting lower values. Lastly, again, we are working for that to reach cutoff values. And lastly, they found that increased perfusion fraction in glioblastoma, more in lymphoma, and that we can use this for monitor treatment response with follow-up. The gradual follow-up, gradual decrease of these values will point to better therapeutic response. And I thank you very much.